Now, we always look for an ideal inotrope. In a broad sense, what you are looking at is, you are looking at an inotrope which is going to increase your cardiac contractility or cardiac output, that is, improve in the performance of the myocardium without having an increase in the myocardial oxygen consumption or any arrhythmic potential. So you want the inotrope to increase the performance without having any negative effect. Now, if you broadly classify the existing drugs into vasoconstrictor, purely vasoconstrictor, purely vasodilator, and have an inotrope having both inotropic action as well as the constrictive action, and you have the last group of drugs which are inodilator, who are having an inotropic action combined with a vascular dilatation. Now, when you use inotrope or inodilator or vasopressor or vasoconstrictor, what's the two important things we should avoid, or we should make sure that it doesn't happen? One is suboptimal administration. If the drugs are administered suboptimally, that may compromise end organ perfusion, so it may result in short and long-term morbidities. If on the other hand, if not properly titrated, it may induce an abrupt, excessive, potentially harmful afterward increase, indirectly blood pressure. So on one hand, you make sure that you are having an optimized dose of the particular drug. On the other side, we are trying to avoid the harmful effect of the extended pharmacological action of that particular drugs. So you can increase the stroke volume most of the time by increasing the heart rate, increasing the blood pressure, increasing the inotropic action. And you can increase the stroke volume by increasing the contractility as well as reducing your systemic vascular resistance, that is dilatation. If you look at the effect on the myocardial oxygen consumption, these three main common mechanisms by which we are increasing the stroke volume have a negative effect. That means not only they are increasing the stroke volume, they are increasing correspondingly, they are increasing the myocardial oxygen consumption. So that is very, very important point to be noted. Now, I just shown overall how these drugs are acting. Most of the time they act on the receptors. So most of the commonly used drugs like dopamine and epinephrine and norepinephrine are dose dependent. So the dopamine and epinephrine, the initial dose, they are increasing the inotropic action. When the dose is exceeding certain limit, they are causing vasoconstriction. So you can call them as inoconstrictors. And dobutamine is having an increase in the rate as well as increase in the contractility, but it is a inodilator, that is, it reduces the systemic vascular resistance. Most of the time above 7.5 mics to 10 mics dose. Now we have another class of drugs. One is milrinone and the levassimandon. The advantage of milrinone is we know that it is phosphodiesterase inhibitor and having a diastolic relaxation and minimal increase in oxygen demand. So you have a drug which is increasing your inotropy and vasodilatation and not having any negative impact on the myocardial oxygen consumption. And then another group of drug which now we tend to try to use it in more often is levassimandon. It's the mechanism action is different than the other inotropes and it is having a cardioprotective action. So it's an inodilator with a cardiac protection action.